Okay, so welcome everybody. For anyone that doesn't know me, I'm Kim Adams. I head up the Local Care Partnership Development team. This is going to be a bit of a mix of a group of us working across the system presenting to you today, but I'm going to kick off with just giving you a bit of an overview of what we're going to cover in this session, and then a little bit of a background of where this came from. And then we've got colleagues that are going to talk in a bit more detail about MyCare itself, where we've got to with the processes, and hopefully give you some time at the end to be able to ask any questions that you might have. Next slide, please, Catherine. So the MyCare project, which is a health tech project, is sitting as part of a much broader programme, which is the Home First Phase 2 programme. So this is a partnership priority that all partners across health and care in Leeds have signed up to, and the particular bit that this sits in within our Home First programme is the neighbourhood proactive care model. So for you in primary care, you've been working proactively, taking this proactive care approach, going into your system and identifying people that you want to proactively work with. I know many of you have got proactive care teams that work across your primary care network. So you absolutely get what proactive care is and what it looks like. Within this stage and this approach with proactive care, we're wanting to make sure that there are two things that are levered into it. The first is that we're using a data-informed approach. So we're pulling data, not just from primary care systems, but from the other systems across the health and care partnership as well, so that we've got that whole picture of what is happening for people. And we're using that data to say, are there some people that might not be on your radar in primary care? So a lot of these people will be people that you know, people that you are seeing in and out of your surgeries all of the time. But there might be some people that actually they're not popping up in primary care. It's other bits of the system that they're popping up in. And if we can encourage them and support them to seek the right help, then they may be getting better support and better joined up support by accessing in that way. The other thing is that we know that the join-ups between services are not always as great as they can be, which means that if we're not talking as effectively as we can with each other, we're potentially duplicating efforts. So again, with this phase of proactive care, it's about making sure that those other partners are wrapping around you in the neighbourhoods, that you feel like you have got this network of people that you can draw upon that actually feel like they are part of your team, rather than feeling like you're pushing referrals out to different organisations and then needing to chase and follow them up. So that's kind of what we're trying to do headline wise with proactive care. As part of that, it's then a case of us trying to spot patterns and gaps and areas that we can improve things more. If you move to the next slide for us, please, Catherine. So we've asked, as part of the PCN DARES, that each primary care network and its constituent practices choose a cohort of people to work with this year. And we've given a choice of 3. So people can work with people that have got multiple long-term conditions, people that have got moderate to severe frailty, or an overlapping group that have got both of those things. And we're asking each primary care network to work with approximately 2 to 3% of their population that fit within these cohorts. And this just maps out, if we were all to focus on severe, moderate to severe frail, they're the actual numbers that we're looking at for each primary care network. And together it adds up to about 600 to 900 people across the city. So we go from working with relatively small numbers in this focused way on each of our neighbourhood footprints to across the city, starting to see some real patterns and hopefully being able to start to measure some real impact when as a system we're all working as a team together. Next one, please, Catherine. So one of the things that we did is we looked at the data and we looked at some of the things that are driving people into unplanned care and staying in hospital. And for the frail cohort, one of the biggest ones is falls that reduce result in fractures. We then really focused down on 2 of our local care partnerships, Armley and York Road, and looked at what are the things that make it more likely that somebody is going to fall, have a fracture, end up in hospital, and then what are some of the things that we might be able to do that could prevent that going forward. And we looked at what are the things that we can draw on that help to predict the people who are more likely to have a fall. And that is where we've then got to MyCare. And we've managed to secure some funding for this year to pilot what MyCare might look like in primary care. And this is what we're talking to you about today. Next slide, please, Catherine. So the reason that we think that MyCare is a really good fit with this particular piece of work is that we know that falls are one of the things that have a huge impact on people, can really be life-changing in a negative way. But we also know that it has a huge impact in terms of people then needing to stay in hospital. We have seen a reduction in falls in the city, and we really are doing a lot of work around falls and have been for quite a while as a system. But we also know that there are some challenges still. So this is around how can we get in there earlier with people? How can we get to them and do interventions before they're starting to fall, when we can maybe have more impact? Next slide, please, Catherine. So I am now going to hand over, I think, to Hannah, who is going to start to talk us through MyCare and then to the MyCare team.
Hi, thanks everybody. My name's Hannah Roden. I'm a Digital Innovation Officer at the Integrated Digital Service in Leeds. So I am going to very quickly just talk through these next 2 slides because we have got some friends from MyCare on the call who can probably talk about this a lot better. But for the purpose of time, I will kind of whiz through these slides and then hand over to them to kind of show you the dashboards and what that looks like. But in terms of the MyCare itself, it's, as you can see on the screen here, it involves some sensors that are placed in different rooms around the house, the bedroom, the living room, and those are just motion sensors. You know, they're not cameras, they're not picking up any sound or anything along those lines. And then there's also door sensors as well, which could be put on the front and the back door and things like the fridge door as well. So it tells you whether those are being used and how often. It also comes with a smart plug, which isn't in the picture there, but that's usually put in the kitchen at where the kettle's plugged in to show how often the kettle's being used. And then in the middle there, you've got the MyCube, and that's the kind of personal health device, and it acts as a bit like an Alexa. Think of an Alexa, it talks to you, but it uses Monica instead, and Monica is their health coach, and Monica will let people know when their medication is due, when they've maybe got appointments that have been registered in the system. It will encourage them to keep hydrated if it recognises maybe that they're not being as hydrated as we would like. Encourages them to keep active if that's appropriate for them, and can also engage in kind of, you know, breathing exercises and things like that, you know, to help people to maintain their physical and mental well-being whilst in home. There's an option there of a smartwatch as well, which counts as steps. What's really good and what we're really excited about with MyCare though as well is that the MyCube includes gait monitoring. So through using sound, it monitors a person's gait as they move around the living room, usually, because that's usually the most used room and where the MyCube would sit. And just by using sound to listen to a few steps each day, it can begin to build up a pattern as to what somebody's normal gait is like, and then be able to trigger alerts when changes start to happen. So by building up this picture of what somebody's normal day-to-day activities are, the system then allows us to start to trigger alerts when things start to deviate from that, and then for the teams to start to take some action and have a look as to, well, what's going on and what would the appropriate action need to be based on those alerts. If we just jump onto the next slide, please. So in terms of what it can do, and looking at other pilots that have taken place already in Leeds with MyCare, but across the country as well, the benefits of this are really looking for us to help with that reduction in falls and falls related injury. Service users have reported quality of life improves, the ability to stay at home independently for longer. It provides greater peace of mind for families and carers because they can be given access to the dashboard and they can see for themselves that, oh, yep, my mum or dad have got up and switched the kettle on this morning as they normally would do, or I can see they've had a good night's sleep last night. So it provides that extra bit of reassurance for family members and carers. Looking through by reducing those fall, a reduction in the number of ambulance call outs and hospital admissions and unplanned bed days, and that reduction in intermediate care demand as well. The potential as well, if we can link in with adult social care, being able to help us to reduce the number of domiciliary care packages. And again, by us understanding what somebody is doing day to day in their home, on their own without people being there, it just helps with that right sizing of care packages, which may be in some cases, and in the previous pilot, we actually ended up putting in an extra visit for somebody because we found through MyCare that they weren't actually going to bed of an evening. They were staying sat in their chair all night. So we put in an extra visit to make sure that that gentleman was getting to bed each night. And with that longer term aim of that reduction or delay in people going into long-term residential care. So like I mentioned, it measures gait and transition time and the number of steps taken, usage, sleep time and quality, those indications of hydration levels through the smart plug and fridge door sensors, and as I mentioned, Monica, that conversational kind of AI health assistant, which can provide those different prompts there. We are still going to use telecare, and telecare team are on the call with us here today. So for that traditional fall service where somebody has fallen and they push the button, or either on the pendant or on the telecare box, that service will remain as it is. But we're looking to use MyCare at the preventative end, so to stop those falls from happening in the first place. But should somebody fall, the traditional telecare service will still be there for people to use as normal. I've already talked about what's in the box, and for those participants who maybe don't already use telecare, and who have chosen not to use it because the cost has been a factor, there is some funding in the budget to allow us to pay for that for up to 15% of the participants taking part in this pilot. So we can pay for telecare for them for a year to give them that additional support and reassurance. Next slide, please. So I mentioned that there had been pilots elsewhere in the country as well. So just very quickly, from Luton, their recent evaluation showed that they invested just under £90,000 in MyCare, which delivered an estimated £556,000 worth of savings. And they said that there was clear evidence there that the technology could deliver benefits to some individuals and their families, with the potential to reduce the number of falls, sites visits, improve quality of life, and support them to remain at home for longer. We've taken some learning from their approaches and learnings from, as I say, the pilot that we've previously done. And it's making sure that the success really does depend on people being able to having people there to monitor the data and act on that prior to the decline in health, which we're going to talk about the process that we've got in mind to be able to do that. The participants' acceptance of the technology, and that there is that resource there to be able to take that proactive approach, which is what we're all here today, and the focus is about that move to proactive and preventative healthcare. And that need to ensure that we've thought about data collection right from the start, to help in terms of valuation. And again, we take a learning from that. Through the Redbridge pilot, and this was mainly used in care homes in Redbridge, but the residents of care homes did feel that using Monica did give them benefits and was really helpful in terms of those appointment reminders and general day communication and interactions. They broadly liked the technology, or actually had no strong feeling about it, and that it can be really passive. Monica can interact with people, and you can set those interactions to high, medium, or not at all. And so for some people, the sensors are there, taking the readings. They don't even know that they're there sometimes if they don't want to. But then, like I say, Monica can be set to interact more or less with them as they would like. It was generally well received by staff. The movement monitoring element of the system, in particular, staff felt that did help them to adapt their care provision. And some feedback was, making sure that devices are placed out of sight and ensuring plug sockets are covered to make sure that they're not inadvertently unplugged or switched off or moved. And also, thinking about potentially older people or people living with dementia, potentially forgetting what the technology is. So I was just kind of being mindful of where things are positioned and maybe putting labels on things to remind people of what they are. So some really great learning there from other pilots. I think at this point, if we hand over to Afia, and Afia, if you can just show us the health report dashboard. So what Afia is going to show you now is what we're thinking would be useful for staff within the PCNs to be able to have access to in relation to this preventative model.
Thank you, Hannah. Nice to meet you all. I'm Ophir. I'm ACA's CTO, looking at the technologies, but also working with most of our clients in the UK, mainly NHS Trust, local authorities, care providers, and so forth. Together with me, I have Dexter, which will jump in a couple of minutes and show you some of our data repository, the kind of data we're able to collect and how we use that data in order to infer and generate insights with regards to any kind of risks associated with the users that are using our technology. So I'll just start quickly by showing you a short view of the live dashboard. This is the dashboard that's available for whoever is subscribed to the service. They are able to get access to the data for the specific individual. In this case, that will be Jane, as you can see here on the left-hand side of the screen. They can monitor and see various data points that have been picked up for the individual. They can look at it on graphs. For here's, for example, steps, but that's been, generated, captured by Jane in this example, how that looks like over time. We're looking at an overall wellness score that combines data from vital signs that are picked up by the medical devices or the smartwatch that's being used, sleep quality analysis and scoring these elements, physical activity, movement, transition times, whether they are maintaining activities of daily living, are they cooking their meals, are they going out for their, hourly walk outside every day like they normally do. Because Monica learns their patterns of behavior. She creates a profile of the person. There's a baseline in place, and every time there's a deviation from that baseline over a period of few days, not a temporary one, but if there's something that has changed over a period of time, then she'll raise that as an indication, a smart insight as we call it. And you can see here on the right some examples. Smart insight letting the relevant carers or family members or clinician, whoever has access to the data and is interested in ensuring the individual's safe and okay, she will generate that insight and let them know, hey, pay attention, something has been changed with Jane in this example. She's been using the bathroom more than expected these past few days. Keep an eye on the situation if possible. So it's a soft alert saying, handle that, intervene before that becomes a upper UTI and potentially a fall. We want to prevent that from happening, maybe even an admission to hospital. Another example, changes in sleep patterns, right? So Jane's been changing her sleep habits over the past few days. She's going to bed earlier, waking up several times during the night, etc. All of these are being picked up by the technology that is learning what's normal for Jane and raising that as alerts. On top of that, as Hannah mentioned, there is a gait analysis element within the solution. It's an acoustic technology that picks up gait sounds. It's unique to us. It's a patent that's been registered and being used. It's been trialed across various organizations in the UK, including originally developed with the first purpose-built dementia village. They've used it, and that's part of how we developed it over the years. I'll hand over to Dexter, my colleague, to share his screen, talk to you in a couple of minutes just about maybe, Dexter, a couple of words about the gait analytics element of it, and then share the dashboard and the data that we would be able to extract.
Definitely. So I will be sharing my screen. So hi everyone, I'm Dexter. I'm responsible for the data and AI at MyCare. And for the past decade in my academic work at MyCare, I've been focusing on using the sound of footsteps to extract relevant biomarkers on frailty, fall risk, and progression of neurodegenerative conditions like Alzheimer's, Parkinson's, and dementia. We have run several successful trials on the technology to develop the technology and extract biomarkers that allow us to quickly understand and differentiate how a person progresses in dementia and how their fall risk escalates over time. To give you some very quick glance of how the data looks like and how it's relevant for us. On over here is a sample subject for which we collected gait data for over a year. In September 2021, the green line on the right hand side is where the cadence or number of steps that they took on average were, and over time they slowed down. They started walking slower. The steps become more variable, and we captured that shift to the left, which is on the left hand side. And in March of that year, this subject was diagnosed with dementia at that point of time. So this is an example. And what we do is we look at how their gait behavior changes over time. And the literature clearly states that fall risk is related to the variance in gait. So the more varied the gait is compared to before, the system will give you a smart insight telling you that their gait has been seen more variable over the past few weeks. This is corresponding with their changes in behavior. I'm going to talk about a little bit about the behavioral aspect of that we capture using the sensors that we saw before, and how we together triage these data points to give you a smart insight telling these are the symptoms, these are the observations that we had. The carer now needs to make a decision on how to move forward with this case. Looking forward specifically to the kinds of data points that we have across, we collect around 70 plus data points across their physical, their physiological, and psychosocial determinants of health. So you're looking at physical data points, for example, how they move inside their house. And when we talked about or we use the phrase transition times or transitions, this is a technical term we came up with. What this means is how you're moving between the rooms, because the sensors will be placed in each of the four base rooms, like the bedroom, the bathroom, the living room, and the kitchen, and understanding how they move between rooms, where they spend most of their time, are they standing, are they moving. This will give us an understanding of how active they are and how much time they take to move between rooms. If they are showing high risk of falls, usually what we see their gait speed or their time taken between rooms increases over time. That's an additional data point that we have. Along all of those lines, what we give you is insights. These are called smart insights. Every week, every day, we give you changes or deltas that are happening in the behavior of the participants, and we quantify it and show you trends over time how it's changing. And we tier these insights based on how important it is for you to act on this information. So it would be a tier 0 where we just give you informative insights, and tier 1, 2, 3 is where we escalate to you because we think we have enough data for you to act immediately or take a hard intervention, as we like to call them. So we have data around the daily activity, including how they're using the toilet, how they're using the kitchen, when are they using the kitchen, which appliances they're using throughout the day, their indoor mobility, whether they're using the watch or the smart ring that we provide, or just based on the sensor movement that we can extrapolate how they're moving inside the house, how they're sleeping, when they're sleeping, if there are any changes in pattern in their sleep patterns, when they're going to bed, when they're waking up, are they waking up in the middle of the night? And if they are, where are they going in the middle of the night? This gives us insights about the changes in behavior corresponding to or before or precursing a fall risk. We also triage all these data points that we collect and give very direct risk analysis, like risk scores that we like to call internally, like you can see for fall risk for this subject. We also have other markers along non-communicable diseases, respiratory tract infections, COVID-19, neurodegenerative conditions. And I think the most relevant, based on the cohort that I saw in the previous slides, the risk of freezing gait, a cautious gait, which are very telltale signs of change in fall risk escalation, and obviously onset of dementia. Specific to Monica, this is the last bit I want to talk about. about briefly. Monica is a proactive conversational health coach and a companion. So how is it different from existing like Alexa or Google Assistant, you might say, is Monica is given a care plan, and her job or her mandate is to make sure that the resident abides by the care plan. Monica proactively nudges them to make sure they take small steps like taking the medicine on time, making sure they move about, they do their exercises on time every day, such that in the longer run you have the cumulative health benefit of reducing their fall risk factors proactively. If there are risk factors which are shown or highlighted by the system, they will be given to the carer on the dashboard, which of which shared, and then you can act accordingly. I think that sort of covers everything that data points will be relevant.
Thank you. Just one last sentence before we hand over to the team. What you've just seen is a data catalog, right? It has lots of data we capture, analyze, and generate insights out of. The users that are going to use the system will get just the extract of it, just the highlights, the insights to be able to take actions. But it was important for us to show you what's behind that, what's the actual data that is being used to generate these insights and tell you, hey, this person has a increased fall risk, pay attention. That's the reason why we think that's happening, take actions. Thank you.
Yeah, just to jump in before I hand back over. So from the kind of the two different dashboards that you saw, the one that was colourful towards the beginning, that's what the family members and carers will have access to. The one that was in grey, which had a lot of detail, which appears just kind of explained there, will be tailored to your requirements. You know, what is it that you actually want to see? What are the data points that you're interested in? You know, for the particularly focused on falls prevention, that will be what you and your teams will be able to see. The reason for that was from a previous meeting. The more colourful dashboard does show those alerts, you know, as they are triggered, and there was some concerns around that if, you know, somebody from a PCN team happened to be, you know, just looking into one of your patients and saw an alert was triggered, then they would need to act on that immediately. And we're going to talk about actually what process is and how those alerts are going to be picked up in the next few slides, I believe. But Chris has got his hand up.
Sorry, could you just go back to that last data slide with the charts on it? It just didn't quite take that in. Sorry, I just wanted to understand the range. The one before,
there you go.
Falls risk, yeah, UTI, all of those neurodegenerative.
Yep.
So are you saying that you can specify that there's certain patterns that you pick up for these certain conditions, particularly the kind of the UTI pattern versus the falls pattern versus?
No, so we are looking at the triaging of all of these data points, the 70 plus data points that we collect, Chris, and then we are looking at what matters to detect or signs of UTI, signs of infection, signs of hypertension, or signs of prediabetes, for example. And we are triaging these risk factors, and we're accumulating and creating a risk score over here. That's what we see over here. But just for, I think we need to be aware, NG 249, which is a nice guideline for falls prevention and frailty, specifically tells you not to use any explicit fall risk scoring algorithm, but instead what they recommend is you use a combination of assessment done by a person or by Monica in this case, who goes through a list of questions that can be done on a periodic basis. Combine that with risk factors, which we will provide to you for the clinician or the carer to make a decision.
Did you just scroll down to the UTI bit, which was...
Sure. Yeah, there you go.
Okay. And respiratory?
So this is again specific to this subject.
Okay, lovely. Yeah, thanks for that.
And shall I finish with the last few slides? I'm just aware probably a number of you have questions, so not many slides to go on, and we're going to open to a Q&A session. I'm just going to bring the slides up. Okay, so today also we're looking to understand which areas have an interest in being part of this work. But there's already been a group of us working on this, looking to pull some guidance together in the background. So based on kind of working with my care colleagues and other colleagues on the call, we've developed a population of focus. There's quite a few points in here, but I think probably the most specific ones would be those people with moderate to severe frailty, people who've been identified as being at risk of a fall or who have fallen in the last 12 months, and probably people who live alone. Clearly, as you've seen, the measurement depends on sensors. We do have some additional, I suppose, little sensors to give carers or pets that will make sure that that equipment knows that this isn't the person. But they're probably some of the key elements of our populations of focus. And we can share this afterwards. In terms of process, as Kim said at the beginning, we'd really see this as complementing that work that we know you're all doing on identifying that population for proactive care. And we know many of you already have that proactive team in place already. And what we're suggesting is that there's work between PCN colleagues and partners to identify people suitable for the pilot, and some support will be available in terms of searches. There is a possibility of us also having access to an eFalls predictor also, which could help in terms of better identifying those people who are likely to be at risk of fall. So the idea is that we'd run that kind of data and search for any PCN that's interested, although of course we know that you may have some people already in mind who may be suitable for this. I use the word care coordinator there. I'm aware that there's different people with that type of role in every area, but somebody then onboards the person, completes any kind of care planning, and takes any information required, and we will make sure, of course, that communications materials are available, but there'll be some training for any PCNs and other colleagues involved, etc. Once somebody has been onboarded and identified as suitable, the equipment will be installed by our telecare colleagues from Leeds City Council, who can also support the carer in installing the dashboard onto their phone also, if that's something that person wishes to happen. And then telecare will monitor and act as that initial monitoring hub for the system, and they'll make a decision based on the type of alert that comes through, which I'm going to cover on the next slide in a little bit more detail. And follow-up action will be taken by the appropriate agency. And then what we really want to do is to make sure if you sign up for this pilot, you know, you won't be alone. We would want to be bringing everybody together regularly to see how things are going, to make any kind of continuous improvement approach to that process, and make any changes required. In terms of directing alerts, again, I won't go into this in any massive detail, but we've been working on what that might look like. So an alert will come into telecare, and then telecare colleagues will contact the person, and then there'll be a decision point. Now, this really is a proactive piece of kit. It's not meant to replace any type of urgent care service that's already in place. However, if there are any concerns by telecare, they're very well linked into the Yorkshire Ambulance Service, and depending on what that concern is, they would call either 999, or they've built up really good relationships with the urgent care paramedic. So it's possible they might suggest to go down that route, which would mean that somebody would come out and see that person, but not necessarily with a view of taking them into hospital. However, there'll be other things, as you saw from the alerts coming up, that are more slight changes in movement, gait, etc., where action required isn't immediate, and that is where primary care networks colleagues would be alerted, and there'd be an agreed process in terms of the point and the route in order to do that. Also, it may be that that telecare colleagues contact the person, and it may be that there's absolutely no cause for concern. For example, an example given in the slide is I've stayed in bed longer because I've got a chest infection, but I've already been to the GP and I'm improving. What we felt as a group was that telecare would still inform the PCN of this, although perhaps say this is a response, so it wouldn't, but it's more to notify you rather than to necessarily alert you. And then for each person, as we mentioned earlier, there is the option for the dashboard to be on a carer's phone, for a carer to be able to see that that information, and also for potentially a carer to be informed in some circumstances. For example, if a person they cared for was taken via 999, they'd contact that carer, being an example. But that's why the care plan will be so important, because it will depend on the needs and circumstances of the person. And what we're really aiming for, we've got some support from our evaluation service within the ICB to evaluate this project, because we really do want to understand if it makes a difference, and if it makes a difference, look at doing kind of more of this, and to prove a case for if this works or not. So we're looking for better outcomes for the person, remaining independent, etc., for a family member and carer. And certainly in the evaluations that I've read from the other areas, that really did come out quite strongly at how this provides peace of mind to many family members and carers. For staff, feeling they can better, it might support them in proactively managing a population, and for the system in terms of in terms of ideally a reduction in some preventable activity through intervening early. So in terms of what of the offer, there's the opportunity to be amongst the first in Leeds to test this this technology. And clearly, Kim mentioned the kind of 2 to 3% of a moderately severe population. If you're doing this with these people, they'd certainly be counted in that. We'd provide support in population identification. And as you can see, we've also already had the development of some core processes, but any PCNs who are involved would be certainly invited to help us to shape this. There'll be the provision of the equipment, and telecare undertaking the central monitoring. And unfortunately, John from telecare has had to drop off the call, but certainly telecare colleagues have generally been on these calls, and to kind of build those relationships with everybody. The provision of data to support the conversations with those patients, as you've just seen, and to support kind of understanding in how that activity of that patient has changed, and also support. I know Abs on the call will offer any support to work with any PCN who that signs up for this to develop to work through how this would work in terms of your multidisciplinary team, how this would work in terms of embedding in your PCN processes. There'd be a single evaluation approach, and also support to adopt a continuous improvement approach. The ask of the PCNs would be to take as a minimum 5 kits. We have 60 kits in total, and we would like to use them all. And so clearly there'd be the potential to take more than 5, but really a minimum of 5. And to work with your partners to select the population based on any searches that you ask for, that will be provided. As we mentioned, it's ABS has been involved in developing these processes with the LCP team, and is really keen to work with any PCNs that sign up to this to work through what would happen when an alert comes in through to your PCN. We understand that every PCN is different, with different teams in place, different staff in place, and we don't want to adapt to one size fits all approach to this. So that will very much be done in a bespoke way with you all. We'd ask you to approach the people you think would benefit from the pilot, and as I say, support will be available to do that. So whoever will be doing that will we'll have the materials, and we're also compiling some frequently asked questions to complete the care plan and identify the best way for telecare to inform the PCN, which will be linked to the work with ABS. And then to pick up on any alerts as they come through, although it may not be that you feel that that alert needs to be picked up by somebody within your immediate primary care team. It may be that you actually think it would be better picked up through perhaps a third sector colleague in your multidisciplinary team or another organisation. The PCN will be just kind of where these alerts are channeled through to. As we say, there's 60 kits in total. It's a 12-month project, and we would like to be starting around November and December time this year. There's just a little bit of work ongoing to integrate the MyCare technology with the telecare technology. But I'm going to pause there because you've heard a lot, and we wondered if anybody had any questions. Claire.
Does this require the internet then?
It does require the internet. We
Right.
recognise that not everybody has the internet, so we do have access to some dongles for those people who either don't have internet or maybe don't feel they have got reliable internet. So we do have access to dongles.
Yeah. Thank you.
Thanks, Claire. Joanne.
Hi, I'm just going back to the slide where you sort of said the different things that can happen when alerts come off, and I guess I was just thinking about there was quite a gap between there being calling an ambulance and PCN, and I know there was sort of discussions around whether it would include things like LCH and the rapid response services for people that have had falls and gone off their feet a bit and that type of thing. That there seems to be quite a sort of gap there, and I was just wondering around the thought processes with that.
Yeah, of course. Kim, are you wanting to come in on that? I've seen your hand go up.
Yeah, so that was a bit that we're thinking could be linked through that urgent care paramedic, that 111 piece, Joanne. So 111 is a bit of a catch-all there, but that paramedic has then got that link through to that service. So we're not looking at anything that needs an urgent or semi-urgent response going to you in primary care.
Yeah.
You're getting that kind of longer term. We're noticing patterns of change.
Right, that's fine. And I guess it was just that clarity around knowing that LCH could be involved as well, and the pathway into that. Thank you.
Yeah, we're using that pathway at the moment with our respiratory project as well, and that bridge from telecare to either 999 or 111. So that feels to be working quite well. Clearly, this is really a proactive piece of kit, but we're just conscious that it may pick up, telecare may pick up situations that we may need to be more reactive to. So keen to put that in place. Claire.
Sorry, me again.
It's okay.
Just so from a PCN point of view, the patients that we have on this, would that sort of have us monitoring it sort of day to day for each patient, or would it alert us on a dashboard if we just had the dashboards up for those patients? And speaking of dashboards, would it be one specific dashboard per patient, or would we as a PCN have an overview of all the patients, if you understand what I mean, that are on our list sort of thing?
I do. Hannah, do you want
me to jump in? Yeah.
Yeah, is
So
that okay? Thank you.
The day-to-day monitoring is done by the telecare team, so they're there, and any alerts that anything that kind of triggers as you need to be aware of this. The telecare team will receive that alert through their existing alarm receiving centre, and they will make those initial phone calls, and they will do that initial triage. Going through those steps. So it's just if it's something that it's not an urgent or an emergency or a rapid response. If it's something that there's just we can see a general decline happening here, and speaking to the patient, things things sound like there's a bit of a downward turn happening. They will then, and to be decided how, but potentially an email to a specific inbox or something to say, you need to have a look at this person. And then what you would then do as a PCN is access that other report that had all the graphs in it. You'd then be able to see, oh yeah, I can see that's going down, that's going up, the sleep quality's not being great, you know, they have been using the bathroom more. So it gives you that bit of extra information then for you then to kind of have a bit more, you know, insight as to what's potentially going on with that participant, and then decide, you know, who's the right person, you know, to then pick up and deal with whatever's going on. You'll have the information from telecare, you know, what the patient said to them when they've had the call, what the alert was, and then all that extra insight through MyCare as well. So no, it's not a day-to-day thing, and you know, we're only talking small numbers of participants here. And again, it's whether, as you know, as you're developing your proactive approach, what does that look like? Does that mean that you're going to look at these specific people once a week, once a month? But again, you're going to have access to those dashboards, that when you're doing that anyway, you're going to have that extra information there through the MyCare dashboard. And yes, it would be, I'm assuming, probably a fear, you know, each PCN, you'll have your patients, you know, on the dashboard, the 5+ number, you know, and then you'll click on their name and then their information will come up, you know, on the screen, and that'll be for each different PCN to have access to their patients.
Yeah, I would just ask it in respect, because we have a proactive care team, integrated care team that we're developing further, and this would be sort of quite a useful tool for us, like you say, and I just wasn't sure if where the actual sort of monitoring would sort of lie, but yeah, thank you for that.
Great.
Thanks, Hannah. Verinda?
Hi, I was just, apologies if I've missed it, but is the logic of this to stay with one cohort, or say for your 5 patients through the entirety of the trial, or if a patient was to sort of be deemed to reduce their risk, would we then be okay moving on to another member of the cohort for whatever reason?
Do you want me to jump in again?
Yeah, that'd be great. Thanks, Hannah.
I think we expect probably the majority of participants to be on for the full 12 months, and you know, but that there may be people that, you know, for whatever reason they've been identified, you know, as a person at risk and somebody that we would like to take this proactive approach with, and you know, through a shorter period, maybe within 6 months, we feel actually that person is no longer at risk of a fall, so we don't feel that there's any benefit of continuing. So yeah, we have the ability to bring the kits back, clean them, you know, wipe off the information, and you know, give it to somebody else. That is possible. But I think we've probably envisioned, though, that most participants will kind of have that longer term need. You know, that they will be kind of in the frail cohort that would continue, so that they would most likely be at risk of a fall for the full 12 months of the pilot.
And the reason I was asking that was just thinking sort of on your potential acute falls, delirium type pictures, and preventing things going in there, because there might be some patients that the risk sort of drops over time. But how long does your algorithm sort of take to train up, if that makes sense? How much data do you need for it? And then I did have other questions about the governance and IG side of all this, and how much consent you need to have and give to an elderly patient about management of all their data.
Yep. So in terms of the building of a picture, different elements take different lengths of time, but in terms of the kind of building up the full picture and to get that the gate and everything, we're looking at probably 4 weeks, aren't we, Afia, for absolutely everything to have that full picture there. Is that right?
Yeah, it depends. Some of the algorithms would take days, and a baseline will be in place, and it continues learning and updating and optimizing that view. And some would take a couple of weeks. So yeah, after a few weeks, you have a good, you know, baseline in place that the technology works from that point.
I think in relation to the second point around governance, that's part of the work that we're doing now. You know, Catherine and myself and Catherine Jeffries, and we're working with Carrick and Blaine within IG. We're going through all of those things, but yes, consent. You know, we will be looking to get informed consent from the participants. So there will be a sheet going through explaining, you know, what the technology is, how it works, who's going to have access to the data, and do they consent to taking part.
Thanks, Hannah. And yes, from experience of working between telecare and Lead City Council and PCNs as well, you probably just need a data sharing agreement between your practices and telecare, which we already have drafted. So it's a process we've been through. But yet that's what would need to be put in place for that link between the telecare and the kind of the practices. But as we say, we're just working through the IG implications yeah at this moment. Is that okay, Verinda?
Yeah, that is. Sorry, I've got my camera and mic off
That's
because
okay.
I've got a toddler in my room, opposite end of the spectrum.
No problem.
But yeah, I guess then would that mean that as a PCN we'd need to go, presumably need to go to each practice for a data sharing agreement then, would we? But would we
That's
get
correct.
support with that as part of this sort of pilot program?
Well, yes. So I mean, the data sharing agreement will be sent to you. That will be signed by telecare, and you'll just need to make sure that your practices are aware and have signed it and sent it back from the data controller.
Thank you.
Chris?
Interesting question about the IG. Who is the data controller here?
Still general practice, isn't it?
Well,
It's the home practices, I would say.
Except this isn't general practice owned kit, is it? It's
the
actually,
ICB.
it's not even that though, is it? Ultimately, you're giving kit to people who want it, and it's up to them to share it with people who can respond to it. Anyway, I won't get into the details of it, but we will need to know who is the controller, because we're not, it's a funny one, isn't it? I mean, you're offering them the opportunity and they take it up and then they become the owners of the data. It's their dashboard.
Absolutely. We're just working through it with data controller. There's a couple of sources. So we're just building a network map and picking through it. We feel confident that we will be able to pick through it, but yes, we're just drawing.
It's a tricky one, yeah.
It's just those tricky questions, like you say, just tricky one to unpick. But we're on track to get it done. Any further questions from anybody? No? Claire?
Sorry, just the last one with Chris saying that. Are we dealing with patients with capacity?
What we have said, it is on the slide, but I've forgotten the exact wording. So I will. No, because I didn't work the whole way through the slide because there was quite a lot of detail on there. Can consent or has an existing LPA.
Right, yeah. Thank you.
No problem at all. Okay. So if there are any questions, then you get off this call and you think I should have asked this question, please just email the team, and we are pulling together a list of frequently asked questions which we will put in a central place also. But please do just ask us a question. If there's anything concerning you, anything you want to talk through, anything after the call you kind of think, oh, we should have asked that, and please do get in touch. Abs, do you want to present the final slide? Shall I bring it up?
Yes, please. News. Yeah, thank you, Catherine. Yeah, hi everyone. As Catherine mentioned earlier, we do understand that each PCN are unique in their own way of working. So if at all your PCN is interested in being part of this special program, because I can see so many of you have been asking questions, which is a good thing. That means you're eager to be part of this special program. Please do contact me and I'll be there to walk through the process of how this is going to work with your PCN. My email is on there, but if you can see it properly, I'm going to drop it in the chat. I know I work closely with most of you anyway, so I'll be looking forward to working with any PCN that is interested in being part of this special project. And if you have any questions like Catherine asked, please do not hesitate to ask. The more questions you ask, the better for us to put a great FAQ together
for other PCN as well interested in being part of this. And I can see you, if you see Kim's screen bolding, it's just because we're in the same room. So I might be looking like I'm on mute, but I'm actually here. Thank you, Catherine.
That's great. Thank you. So yeah, if you could just let us know by Monday, the 6th of October, if possible, if you'd like to be part of this pilot, simply because we just need to make sure now we've got the numbers and we start to work with you on this as we look to reach the deadline, and just let us know who you want us to invite to the meetings. And then, as I've said, Ben, he'll be in touch to support in mapping out any associated PCN processes. So that's, yeah, everything. Kim, is there anything you'd like to add?
No, I think that was really comprehensive in terms of where we're at with this. We are still working through some of those processes, so some of your questions we might not have answers to, but that's why we're really keen to get you involved in helping shape it.
Super. We look forward to hearing from you. Thank you very much.